All right, so our next lecture is on the spinal cord, and we'll start out just with a big picture of the spinal cord. This doesn't include all the details, but we can make some general points about some nuclear groups and pathways. First of all, just notice that in the brain we have the cortical neurons out around the surface, and then we have the white matter deep within. In the spinal cord, we have the neurons here occupying this center H-like shape, and then we have the pathways surrounding them. And so this is a drawing done at T1, and these are pathways we've talked about, but now we'll just go over them in more detail. First of all, let's start with the posterior columns here. So we've said the posterior or dorsal columns convey vibration and proprioception to the brain, and arbitrarily we divide T6 here as above T6, it's fasciculus gracilis, below T6, it's fasciculus cuneatus. Since this is a drawing of the T1 spinal cord, this only continues to T1, but if we were to draw or have a section of lumbosacral spinal cord, we'd see the lumbosacral fibers out in this distribution. So notice here that there are distinct columnar arrangements of these pathways. So for the posterior columns, the sacral fibers are most medial, and then lumbar, and then thoracic. And if we were to go up the cervical cord, we'd see the cervical fibers out laterally. So if we follow vibration and proprioception, remember these come in via myelinated, heavily myelinated, fast conducting sensory fibers, and these do not synapse or cross in the spinal cord. So they just come in and ascend right up the posterior columns. So these fibers coming here at T1 then would enter the fasciculus cuneatus and ascend up to the brainstem where we have our first synapse. All right, now if we follow pain and temperature, remember these are small unmyelinated fibers, and pathway here is very different. So we have a synapse, and then the crossing, and then the fibers ascend to the brain in this distribution of the spinal cord, and this, of course, is the spinothalamic tract. Okay, now notice that the columnar arrangement here is exactly the opposite of the posterior columns. Now we have the sacral fibers are lateral, then lumbar, then thoracic, and again, if we were to show a section of the cervical cord, we'd have the cervical fibers most medial. Okay, when we talk about diseases or conditions that affect the spinal cord, there actually is a practical application of understanding whether the fibers are medial or lateral here. All right, the corticospinal tract is here in this location. All right, and so notice here that it follows the same columnar arrangement as the spinothalamic tract. So sacral is lateral, then lumbar, then thoracic, and then cervical. Two other pathways out here that we haven't talked about yet in the course are the dorsal and ventral spinocerebellar tracts. So remember, the cerebellum acts as a comparator. It gets the motor program for the intended movement from the brain, and then it needs to know what your arm and leg is doing with that intended movement. And so information from muscle spindles and Golgi tendon organs ascends up to the cerebellum in these spinocerebellar pathways, so that the cerebellum then can compare the intended with the actual movement. So both the dorsal and ventral spinocerebellar tract provide information to the cerebellum from the legs. Okay, now of course there are two pathways for the arms as well, but we'll just point these out for now. Now, just to point out two groups of neurons here. First of all, we have the anterior horn cells. Okay, and these are located in the ventral horn of the spinal cord. Okay, remember these are the lower motor neurons. Later on, we'll talk about a condition called ALS or Lou Gehrig's disease, and there's a prominent dropout of these anterior horn cells. And so patients have lots of lower motor neuron findings than on exam. Okay, and then a nucleus back here that we will talk about is called Clark's nucleus. And I want you to associate that nucleus with the dorsal spinocerebellar tract. So we will see that the fibers from Clark's nucleus move out and become the dorsal spinocerebellar tract. All right, so that's just a little bit of a big picture. A couple of other things just by way of general orientation. Oftentimes you'll be shown a section of the spinal cord and asked, about what level are you at? And one way you can tell is how big is the ventral horn? Notice here it's very small, very few anterior horn cells compared to this section over here, which is huge. And so the clue here is just to recognize that this is the thoracic cord, about T6, and there are very few T6 muscles. You've got some intercostal muscles, but you don't need a lot of anterior horn cells in the thoracic cord, so the ventral horn is always small. This is T8 of the spinal cord, and notice we have a huge ventral horn. And this is because C8, remember from our last lecture, supplies lots and lots of hand muscles, forearm muscles, so we need a lot of anterior horn cells here. So this is a clue, certainly that we're not dealing with thoracic cord here. Another structure that has a unique location, mainly in the thoracic cord, and it can occur from T1 to L2, is this little nucleus. I'm going to just cover it up right here, but it's this area right here, okay? And this is called the intermediolateral cell column. And the preganglionic sympathetic fibers are located here from T1 to L2. Okay, so remember when we talked about Horner syndrome, we went through the sympathetic pathway that the first order neuron synapse right up here around T1 and then head back up to your pupil. So that's just one example of some sympathetic neurons that are located there. All right, so let's go through some of the specific pathways. So first of all, we have multiple upper motor neuron pathways. So far in this course, it seems like there's only one, the corticospinal tract. But of course that isn't true, and this is where we cover briefly some of the other upper motor neuron pathways. So the lateral motor system is named that way because these fibers travel in the lateral spinal cord. So the lateral corticospinal tract is really the only one we've talked about so far in the course. Now we've just been calling it the corticospinal tract, but to be more precise, it is the lateral corticospinal tract. And then we have another pathway here called the rubrospinal tract. All right, so corticospinal tract. I think hopefully you're all very comfortable with this pathway now as it travels from the motor cortex, and leaving out details here, but it crosses at the pyramidal decussation. And now we're interested in this portion here, the lateral corticospinal tract in the lateral spinal cord. And of course, this is destined usually via interneurons, although not always, to synapse on anterior horn cells. So this is the lower motor neuron. And then, of course, roots, plexus, peripheral nerve, neuromuscular junction, and then out to muscle. Okay, so I think we've hammered the anatomy of this enough, but it's just very important that you remember this travels through the posterior limb of the internal capsule, and then in the midbrain is the cerebral peduncles, basis pontis in the pons, medullary pyramid, not shown here in this drawing, and then we have the crossing. And so here is the corticospinal tract, and so depending on which movement, whether you're moving your hand or your leg, it's going to talk to the appropriate anterior horn cells in the cervical cord to move your fingers and hands, and then down in the lumbosacral to move your leg or foot. Now, in actuality, it turns out that the lateral corticospinal tract has a bias here to supply the cervical cord. 55% of the fibers terminate on cervical cord anterior horn cells, only about 20% thoracic cord, 25% lumbosacral. And so the most significant function of the corticospinal tract is actually invested in the hand. And so here's the lateral motor system here. So we've got our lateral corticospinal tract. And so a lot of this is going to anterior horn cells here that will supply your arm and hand. Okay. It has what we call a mild flexor bias, which just indicates there's a bit more supply to the flexor rather than the extensor muscles. Okay, and so here's the lateral corticospinal tract, and again, just remember the columnar arrangement. Sacral is lateral, cervical is medial. Now, a pathway that travels right along with the lateral corticospinal tract is the rubrospinal tract. And so this is, oops, I don't want that one. This pathway originates from the red nucleus. So there's the red nucleus. And so that's kind of been mysterious so far in the course. What does the red nucleus do? Well, this is one function of the red nucleus. And so this is an upper motor neuron pathway that crosses almost immediately once we get below the red nucleus. And it travels right along with the corticospinal tract. And it has a similar function. It's mainly interested in the distal hand. It has a flexor bias. So it's traveling out in this location and doing basically the same things. Now in humans, it appears that the rubrospinal tract is much less important probably than the lateral corticospinal tract, but they work together. Now we have 4 pathways that we'll talk about here that are in the medial motor system because they're in this medial portion of the spinal cord. And just as a big picture, notice that these are supplying more proximal muscles, the neck, proximal muscles. And that's a general rule for the medial motor system. All right, so 4 pathways. First one we'll talk about is the vestibulospinal tract. And so there are 2 of these, a lateral and a medial vestibulospinal tract. The lateral vestibulospinal tract is the most powerful extensor upper motor neuron pathway. All right, so very strong stimulation to extensor muscles. And in the coma lecture next year, we will talk about decerebrosposturing, which is something we'll see in comatose patients where their arms and legs stiffen. That's a bad sign, has generally a poor prognosis, but the pathway that is overactive in that case is the lateral vestibulospinal tract, and we'll explain later why that pathway becomes overactive. Okay, another vestibulospinal tract is the medial vestibulospinal tract, and this pathway gets information from the inner ear, and it supplies cervical anterior horn cells, so it's only interested in the neck. And so this pathway is very important when you're moving around and your head is tilting from side to side, that your neck can perfectly turn in response to a position that your body is moving. And so just to kind of give an example here, we can tie both of these pathways maybe to explain this. So you slip on ice. Now this individual is falling straight back, but imagine you're falling to one side. The medial vestibulospinal tract then might be important to correctively turn your head. And it does that so precisely because of the information from the inner ears. It's communicating, oh, you're falling in this direction. Also notice like slipping, your arms and legs go into extension. So this would be the lateral vestibulospinal tract that would be involved in trying to make that corrective movement. Okay, not successfully, obviously here in this picture. All right, the next medial motor system is the tectospinal tract. So we referred to this area on the dorsum of the midbrain as the tectum, or the quadrigeminal plate. So the tectospinal tract is a descending upper motor neuron pathway that originates from the superior and the inferior colliculus. Okay? So we said that the superior colliculus has to do with vision, but not visual acuity. And the inferior colliculus has to do with auditory information. All right, so what this pathway does is it also, like the medial vestibulospinal tract, just supplies neck, cervical, anterior horn cells. And so when you are able to, you see something off in the periphery and you're able to very precisely turn your head in that direction, that is the tectospinal tract coming from the superior colliculus for vision. Okay, when you hear something off to one side, and again, you're able to precisely turn your head in that direction, that is tectospinal tract coming from the inferior colliculus. Okay, and so again, tectospinal tract here, part of our medial motor system, and so this is just invested here in cervical anterior horn cells for turning your head. Now the reticulospinal tract, we mentioned briefly the reticular formation in the brainstem. And so this is a descending upper motor neuron pathway that originates from those neurons. And so this can come from the pons or the medulla, and so it's called the Pontine and the Medullary reticular formation, and the descending pathway is the reticulospinal tract. And I've decided not to include a lot of details about this, but what I would like you to know is that they're invested in supplying midline axial muscles. Okay, not out in the extremities, but truncal midline muscles. Last one here we'll talk about is the anterior corticospinal tract. And so it turns out as the corticospinal tract is descending through the medullary pyramid, not 100% of those fibers cross. So about 10 to 15% just continue down on the same side of the spinal cord. But that doesn't end up being very important probably, because these fibers almost always cross before they synapse on anterior horn cells, right? So notice we've got a crossing over here, and there are other of these medial motor, upper motor neuron pathways that cross over, but the anterior corticospinal tract fibers cross and then synapse on anterior horn cells. We don't talk about this pathway a lot, and in fact, in the 3rd and 4th year, when you're rotating through neurology, people love to talk about the corticospinal tract. We use that all the time to localize lesions. And so when you hear corticospinal tract, think lateral corticospinal tract. That's what people are generally referring to. Now, this is a very busy slide. Don't spend a lot of time working on this, but I just want to emphasize the brain has a lot of tools available to very precisely provide for any type of movement that is needed. So we have the corticospinal tract up here, going down through the lateral motor system. Here's the red nucleus, and so this is the rubrospinal tract traveling right along with it. Okay, here we have the Pontine and the Medullary reticulospinal tract in the medial motor system. So remember, these are supplying axial midline muscles. Here's the lateral vestibular nucleus. So our lateral vestibulospinal tract travels down here. Remember, this is the extensor pathway. And then we have the tectospinal tract coming from the tectum. Again, to move your neck in response to visual or auditory information. All right, for the medial motor systems, I really don't, not going to ask you to know whether these are crossed or uncrossed. But of course, we've made a big deal that you know that for the lateral corticospinal tract. That's very important. Now, of course, all of these upper motor neurons are interacting with anterior horn cells to facilitate movement. And I just wanted to make a little point here clinically. If we have a lesion here, let's say we have a disc herniation, okay, and it's pushing on the spinal cord. Well, it's going to involve these upper motor neuron pathways that we've talked about. And so the patient will have upper motor neuron findings below the level of the lesion. Okay? But we also have lower motor neurons here. So the anterior horn cell is the lower motor neuron. The motor fiber that projects from the anterior horn cell is lower motor neuron. And so spinal cord lesions, mass lesions, are often confusing because we get a mixture of upper motor neuron findings and lower motor neuron findings in the same patient. Okay, so just kind of remember that there aren't too many things that give us a mixture of upper and lower motor neuron findings, but this is one. Now we have sensory pathways that we've talked about already, the spinothalamic tract and the dorsal column medial lemniscal pathway. Okay, so pain and temperature again. We've talked about how this comes in via small unmyelinated fibers and ascends for a segment or two as Lissauer's tract. Then we have a synapse, and then the crossing in the ventral white commissure, and then it ascends on the opposite side of the spinal cord up through the lateral medulla. That's really important for later. Synapses on the VPL of the thalamus, and sorry for the typo here, post-central gyrus. Okay, so again, looking on this cross section, here's the synapse. The crossing is the ventral white commissure, and then traveling out in this location is the spinothalamic tract. So the synapse, the most important one to know is in lamina 2. So the spinal cord is classified by these different called rexed lamina or layers. And so layer 2 here is called the substantia gelatinosa. And this is most important for pain information that is entering the spinal cord. So it synapses in substantia gelatinosa and then crosses over here as the ventral white commissure. All right, the dorsal columns or the posterior columns. So we've said somewhat arbitrarily here that above T6, we call it fasciculus cuneatus. Below T6, it's fasciculus grossalis. Essentially, this just means if it's the arm vibration and proprioception, it's fasciculus cuneatus. If it's the leg vibration proprioception, it's fasciculus grossalis. So this information does not cross until we get all the way up into the lower medulla. Then we have the synapse as the nucleus grossalis or nucleus cuneatus. Okay, then the fibers cross over, and the crossing fibers we call internal arcuate fibers. Okay, so you want to associate that with vibration and proprioception. Remember, the ventral white commissure is the crossing for pain and temperature, and that occurs in the spinal cord. Once these fibers cross, we give it a new name. It's called the medial lemniscus. But the medial lemniscus is just the continuation of the posterior columns after it crosses. Okay, same pathway, but different side. So a lesion here would give you loss of vibration proprioception on the opposite side, but you want to just keep the names of the dorsal columns and the medial lemniscus as one continuous pathway. Okay, same thalamic nucleus, VPL, and then again sensory cortex. Okay, and so here we already pointed out the dorsal columns here ascending in the spinal cord without crossing. Now, of course, there are ascending cerebellar pathways as well. We have the dorsal and ventral spinocerebellar tract for the lower extremities. For the upper extremities, the cuneo and the rostral spinocerebellar tracts. Okay, so let's start with the dorsal spinocerebellar tract. And this is an interesting pathway. So again, the goal here is to get information to your cerebellum about where the leg is in space. And so sensory information from the leg, and this comes from muscle stretch receptors, actually enters first the dorsal columns. Okay, and it kind of hitchhikes in the dorsal columns, and it will travel up until we get to L2 of the spinal cord, and that's when we see Clark's nucleus right here. Clark's nucleus, otherwise known as nucleus dorsalis. All right, so Clark's nucleus is where all of the fibers that will become the dorsal spinocerebellar tract ascend and synapse here, and after the synapse, the fibers move out into this very lateral portion of the spinal cord, and again, we call that the dorsal spinocerebellar tract here, and then over here. Okay, so there's no other nucleus really to know that is in this location of the spinal cord. So if you're asked to identify something here, it's Clark's nucleus. But remember, this is really only found from T1 to L2 of the spinal cord. Now, 3 of the 4 spinocerebellar pathways follow this general rule, okay, which is muscle spindles, sometimes Golgi tendon organs. Information about muscle movement goes into the spinal cord. We have a synapse, and then it ascends to the cerebellum, and these fibers do not cross. So information from your right leg or right arm goes up to the right cerebellum. Okay, but of course there always has to be some oddball exception here, and that is the ventral spinocerebellar tract. So this is the other pathway providing information to your cerebellum from the lower extremities. So the stimulus to activate the ventral spinocerebellar tract is via Golgi tendon organs, which we're going to talk about in just a minute. And so this is unusual because it enters the spinal cord in synapses, like Clark's nucleus, all right, but it crosses over. And it crosses over in the ventral white commissure, right along with the pain and temperature fibers. Okay, so it ascends all the way up the spinal cord, the medulla, and it gets into the cerebellum via the superior cerebellar peduncle, which sounds maybe strange to you because we emphasize that most of the fibers in the superior cerebellar peduncle are going out of the cerebellum to the motor cortex. And that is certainly the majority of what's going on in the superior cerebellar peduncle, but here's one exception. This is going into the cerebellum through the superior cerebellar peduncle. Now notice though, it crosses twice, so the information here, if this is your right leg, is still going to the right cerebellum. All right, so all 4 of the spinocerebellar pathways eventually talk to the cerebellum on the same side. Just turns out that the ventral spinocerebellar tract gets there by crossing twice. Okay, don't ask me why it is that way. So here's kind of a summary of the spinocerebellar tracts. So for the lower extremities, it's the dorsal and ventral spinocerebellar tracts. The activation for the dorsal spinocerebellar tract is muscle spindles. For ventral spinocerebellar tract, it's Golgi tendon organs. The 1A sensory fibers, later on we'll go through all of the sensory fibers and what these mean, but 1A is the fastest. Okay, 1B is just a little bit slower. Okay, and in terms of the relay nuclei involved here, I'd just like you to know Clark's nucleus. Okay, and associate that with the dorsal spinocerebellar tract. Okay, the dorsal spinocerebellar tract goes up through the inferior cerebellar peduncle. It doesn't cross. The ventral spinocerebellar tract goes through the superior cerebellar peduncle, and remember, it crosses twice. Now, the 2 spinocerebellar pathways for the upper extremity, I'm actually not going to point them out, but just to know by name. The cuneo spinocerebellar tract is the equivalent of the dorsal spinocerebellar tract for the upper extremity, and the rostral spinocerebellar tract is the equivalent of the ventral spinocerebellar tract, but now for the upper extremity. Okay, and notice spindles and Golgi tendon organs, so we have the same kind of relationship here, that the fast fibers are with the cuneo spinocerebellar tract. They go through the inferior cerebellar peduncle, so notice they all go through the inferior cerebellar peduncle except this oddball ventral spinocerebellar tract, and neither of these pathways for the upper extremity cross. Okay, we'll have a chance to go back over this again because after we go through the brainstem, we have an hour lecture on the cerebellum, and we'll say more about these pathways. Now we're just kind of pointing them out in the spinal cord. Okay, I just wanted to make a point here about our autonomic system in terms of location. All right, so we said T1 to L2, we have the preganglionic sympathetics. All right, well, the parasympathetics are in a similar location, but down in the sacral spinal cord from S2 to 4. Now let's say a little bit about muscle spindles. When we talk about a muscle, like we talk about evaluating the biceps muscle, these are extrafusal muscle fibers. The bulk of any muscle are the extrafusal muscle fibers. But muscle spindles are what are called intrafusal muscle fibers. These have contractile elements, okay? But these are important sensory receptors. And so what we can see here is a nuclear bag, kind of in the center of this, and then we have a nuclear chain. Okay, so this makes up the muscle spindle. And within the nuclear bag, there are two types of fibers. So we have dynamic and static fibers here that make up the nuclear bag. Okay, so the dynamic fibers get the fast 1A sensory input going back up to the spinal cord, and these are very sensitive to the smallest degree of rapid stretch. So dynamic nuclear bag fibers are activated by small stretch. When you do a deep tendon reflex, which really is better called a muscle stretch reflex, so you tap the tendon, that causes this muscle fiber here, or I'm sorry, muscle spindle to stretch. But what is mainly activated are the dynamic fibers here that are part of the nuclear bag. Okay, the other part of the nuclear bag are the static fibers, and these provide more of a constant input to the spinal cord about the degree of stretch. And that's very similar overlaps here with the nuclear chain fibers, which again are more providing a constant information about the degree of stretch. So again, the one that provides kind of like all or nothing, so it doesn't provide much information, but if it's stretched, it sends a lot of information. Those are the dynamic nuclear bag fibers. These are the ones mainly activated when we check reflexes on exam. Okay, so when you think spindles, muscle spindles, you should be thinking of stretch. These are also very important, as we will see, in terms of regulating muscle tone. All right, so let's consider reflexes again. And so let's think about the patellar reflex. So here, again, embedded within the extrafusal muscle fibers, we have the intrafusal muscle fibers, or the muscle spindle. Okay, so this information goes into the spinal cord, and we have a monosynaptic connection with anterior horn cells here to go right back out to the quadriceps muscle. Okay, but via an interneuron, there's also a connection here to the antagonist muscles. And in this case, in terms of leg extension, for your leg to kick out when you tap the patellar reflex, you also, by doing that, actually inhibit the hamstring muscle, which wants to flex the leg. Okay, so again, here it's shown we tap on the patellar tendon, we stretch the muscle spindles that are embedded in the quadriceps muscle, monosynaptic connection right back to anterior horn cells that activate the quadriceps, but in parallel, you activate inhibitory fibers that go down to the hamstrings. Okay, so again, the important points here, there are very few pathways or circuits that are monosynaptic, but this is one of them, this monosynaptic connection for facilitation of reflexes, and reciprocal inhibition is the term that is used for inhibiting the antagonist muscle, in this case, the hamstrings. Now, notice that there are other fibers here as well that we see in red, and these are gamma motor neurons. So remember I said that the muscle spindle, or the intrafusal muscle fibers, these have contractile elements. And these contractile elements are supplied by gamma motor neurons. So these are located in the ventral horn of the spinal cord, right adjacent to anterior horn cells. And so they are very important for kind of regulating the degree of stretch of muscle spindles. Okay, so let's look at this. First, here's our anterior horn cell. or our alpha motor neurons. So we've talked about that supplying muscle. Okay, and again, when we say muscle, we mean the extrafusal muscle fibers. Okay, but here we've got a spindle. Okay, now it's embedded in the muscle, but we're drawing it out here. And so the muscle spindle is supplied by these gamma motor neurons. Okay, and notice that the gamma motor neurons, just like the anterior horn cells get supplies from upper motor neurons, the gamma motor neurons also have upper motor neurons that regulate their activity, and that is important. All right, so let's try to explain the significance of this. Here we have the bulk of the muscle, the extrafusal muscle fibers. Here we have the intrafusal fibers, or the muscle spindle. All right, and let me turn the light on here. It's kind of dark. And so what happens here during stretch? Let's say we have a contraction of a muscle. Let's just say this is the biceps. And so here is stimulation, electrical impulses traveling from the anterior horn cell down to the biceps to contract the muscle. And this middle section is kind of a theoretical, it's kind of to make a point of what the gamma motor neurons are doing. But notice, if we didn't have gamma motor neurons, when you contract your muscle, well, look what happens to the muscle spindle. It kind of gets squashed. And so it's not tight. And in this state, it would not be able to respond to any stretch. It wouldn't be able to provide that very finely tuned information to the spinal cord about the state of stretch of the muscle. And so what happens then when you contract the muscle, notice that there is electrical input immediately coming from the gamma motor neurons to contract the muscle spindle. Okay, so the muscle is contracted, but now the muscle spindle is tight as well. All right, and so the importance of that is now, even in this contracted state of the muscle, the muscle spindle is still able to provide very precise input to the spinal cord about any degree of stretch in the contracted state. Okay, so the gamma motor neuron is always activated in parallel with anterior horn cells to maintain that finely tuned needed information. Okay, so we call this a co-activation of alpha and gamma motor neurons. So the concept here is that the gamma motor neurons are constantly keeping those intrafusal fibrils tight to allow for a very sensitive response to any stretch. All right, so this has a clinical application. We've said that if someone has upper motor neuron lesion, they have spastic weakness, and we've said that that is velocity dependent. And it's more complex than this, but part of the picture appears to be, remember I said we have upper motor neurons that are interacting here with gamma motor neurons. And a lot of these are inhibitory. In fact, the majority are inhibitory. So if we have an upper motor neuron lesion, we lose that inhibition, that finely tuned control over the gamma motor neurons. And so now they become relatively overactive. They're always keeping the muscle spindle tight. And so that's what leads to the spasticity with upper motor neuron lesions. That's why upper motor neuron lesions produce velocity-dependent spastic weakness, where you move the muscle spindle is so tight that the muscle contracts. Okay, so part of the picture of why do patients, why do upper motor neuron lesions produce spasticity is explained by loss of inhibition on gamma motor neurons. All right, the Golgi tendon organs are other sensory receptors. Remember we talked about these providing input for two of the spinocerebellar pathways. So these are encapsulated nerve endings that are at the junction of muscle and tendons. These provide input to the spinal cord via 1B axons, and they are connected in series with the muscle fibers. Okay, So, sorry, this can't be seen extremely well, but here we have the biceps. And so the Golgi tendon organs are kind of right here at this muscle tendon junction. And so if we're just to follow this pathway via an interneuron, what actually happens is during contraction, this actually inhibits the agonist muscle. This is inhibitory right here. Okay, and again via an interneuron. This is should be a positive sign here. It doesn't show up very well, but it actually stimulates the antagonist muscle. Okay, and so Golgi tendon organs, unlike muscle spindles, which mainly are responsive to stretch, Golgi tendon organs are mainly interested in contraction and tension in muscles. Okay, and so they provide this negative feedback loop. Okay, now why would you want a negative feedback loop on a muscle that you're trying to activate? Well, this appears to be really important with very fine activities, like let's say you're doing something with your hands, you're doing a medical procedure or something. And so kind of what's missing here in understanding this is just to realize that our descending pathways are constantly, the brain is using this to very finely regulate movement. And so this can be just finely tuned to allow you to appropriately contract maybe agonist and antagonist muscles at the same time to do something like a fine procedure, or just writing with a pencil would be the same kind of activity. Now, probably at extreme levels of muscle contraction, this may actually be protective. So you're trying to lift a weight that would be harmful to the muscles. Then you get a very powerful inhibition on the agonist muscle to prevent muscle injury. You collapse, you let go. So the point is, at small levels of force, like during a procedure or something, Golgi tendon organs are important for the appropriate increasing or decreasing inhibition of anterior horn cells to maintain a steady degree of force. Okay, and so again, I think about a procedure, one that I do is injecting the eyelid sometimes for blepharospasm. Well, I want to be able to very finely control that movement, and the Golgi tendon organs are probably important for facilitating something like that. And again, at extreme high levels of force, it may be important to protect muscle from damage. Okay. Now, muscle spindles and Golgi tendon organs, we've shown that these have input to the 4 spinocerebellar pathways. This is what's known as unconscious proprioception. Okay, so the ability of your cerebellum to provide that function as a comparator between intended movement and actual movement, to compare that and to provide a corrective movement. But the muscle spindles and Golgi tendon organs also are important in terms of the information that becomes the posterior columns. And so that is knowing where your limbs are in space. That's conscious proprioception. Now, there is a reflex here that also involves these spinal cord circuits called the flexion crossed extension reflex. So if we just imagine here stepping on a tack, okay, what do you want to do? Well, you want to withdraw your leg, obviously, and so that's going to involve contracting the flexors, right? You want to use your hamstrings to pull that leg away. And so what happens here is, again, the only one that's monosynaptic are the muscle stretch reflexes. Everything else is via interneurons. And so what happens here is you are going to stimulate the flexor muscles. These contract to draw the leg away. And so you don't want your leg straightening out, right? That would be quadriceps pushing down into the tack. So we inhibit, in this case, the extensor muscles, and the leg draws away. Right? But if you just imagine lifting your leg up, pulling it away from a painful stimulation, well, now we need to balance on the opposite leg, right? And so this leg needs to extend. And so we have a pathway that crosses over then, and now to activate the extensor muscles, the quadriceps, and to inhibit the flexor muscles, the hamstrings. So this is called the flexion crossed extension reflex. Okay, well, now how often do you step on a tack? Not very often, but probably more important, we just kind of use that to illustrate, this is what is going on when you walk. So continuously, you're putting balance on one leg, removing it from the other, and so these kinds of circuits just illustrate a little bit kind of the complexities, what is going on in the spinal cord during walking. Okay, and just, the upper motor neuron control really is not very well understood. So we've talked in this lecture about all of the upper motor neuron pathways that regulate these lower motor neurons and spinal cord circuits. But we have an incredible ability to contract agonists and antagonists at the same time. It's just amazing what goes on to catch a ball. All of the upper and lower motor neuron pathways that have to be working together very well. And just as one more little example of this, kind of think of these interneurons and little connections in the spinal cord. It's like the keys of a piano. The upper motor neurons are regulating everything that's going on. So one interneuron here in the spinal cord are called Renshaw cells. Okay, and so here we have an anterior horn cell supplying an individual muscle. Okay, and notice as it does that, it actually activates Renshaw cells. Sorry for my dog there. And so notice that the Renshaw cells, they actually provide a negative feedback loop right back on the agonist muscle. Okay, and so the significance here is really that the descending upper motor neuron pathways are able to influence these and therefore can provide a role in regulating movement. Okay. Now, I think we will start from here in the next lecture. What we're going to do is we're going to follow pathways in the spinal cord and continue to see those as they work their way up to the brainstem.